Welcome to Pulse&Pressors, where critical care gets crystal clear. Today, we explore isoproterenol, a medication that acts like pure electrical fuel for the heart. It's a beta agonist without alpha activity, meaning it speeds things up but never clamps down. In the ICU, this drug is both rare and powerful. It's the spark plug of the conduction system. Isoproterenol is a non-selective beta agonist, meaning it stimulates both beta 1 and beta 2 receptors. Beta 1 activity increases heart rate, contractility, and conduction through the AV node. Beta 2 activity opens blood vessels and airways, lowering systemic vascular resistance. The result? Your cardiac output climbs, but your blood pressure may drop. Think of pressing the gas pedal while releasing the brake. Isoproterenol's power lies in its ability to fire up the SA and AV nodes. It accelerates the heartbeat and improves contractility. But because it dilates vessels, it may reduce blood pressure. And because it drives the heart so hard, oxygen consumption rises. That's why this drug is used only in specific controlled ICU settings. Hemodynamically, isoproterenol increases cardiac output mainly by accelerating heart rate. It's a flow-boosting drug, not a pressure builder. While the heart pumps faster and stronger, the vessels relax, and the mean arterial pressure can drop. In ventricular or ischemic rhythms, it can be dangerous, increasing oxygen demand and aggravating arrhythmias. In short, isoproterenol buys time until pacing or recovery, not a permanent rhythm solution. We reserve isoproterenol for very select moments. When atropine fails and pacing isn't ready, it's our pharmacologic pacemaker. In torsades caused by long pauses, we use it to shorten QT intervals and prevent R on T. For denervated transplant hearts, it replaces the vagus entirely. It can even help in beta blocker overdose or EP testing, but always under close watch. After cardiac transplantation, the heart loses its nerve connections. Drugs like atropine have no effect because there's no vagal input to block. Here, isoproterenol shines. It bypasses the nervous system entirely, directly stimulating beta receptors to keep the new heart beating until conduction recovers or pacing is established. In a normal heart, the vagus nerve constantly applies a small brake on the SA and AV nodes through acetylcholine. When we give atropine, we lift that brake. The parasympathetic input is blocked, so the heart rate rises. But in a transplanted heart, those nerves are gone. The new heart is denervated, meaning it has no vagal fibers and no sympathetic fibers. There is no acetylcholine being released, no brake pedal to lift. So atropine has nothing to block, and the heart rate doesn't change. Instead, we turn to direct-acting beta agonists like isoproterenol or epinephrine, which stimulate the beta 1 receptors on the heart muscle itself. These drugs work even when the heart is disconnected from the nervous system. That's why isoproterenol is called the chemical pacer after transplant. But every spark can burn. Isoproterenol should not be used when oxygen supply is limited, such as after an myocardial infarction or an unstable angina. It can worsen tachyarrhythmias and drop blood pressure in distributive or cardiogenic shock. In hypertrophic cardiomyopathy, it exaggerates obstruction. Respect this drug. It's a scalpel, not a hammer. Use isoproterenol with extreme caution when pressure is already low or when the myocardium is ischemic. Its vasodilatory nature can collapse a fragile mean arterial pressure. Always preload and support perfusion first, sometimes with a balanced pressor like norepinephrine. Let's talk rhythm. Isoproterenol is not for every bradycardia. It's for the ones you can't reach with a pacer yet. It's life-saving in torsades with long pauses, keeping the heart fast enough to prevent degeneration. And in the transplant heart, it's the go-to chemical pacemaker. Who should get it? The perfect candidate is a monitored patient with reversible bradyarrhythmia, especially a transplant heart or Torsades pattern. Who should not? Those with ischemic myocardium, active tachyarrhythmia, or shock states where vasoconstriction is needed. Isoproterenol drives flow, not pressure. The infusion starts at 1 microgram per minute and can be titrated up carefully. Onset is nearly immediate, with a short 2-minute half-life. Always use continuous ECG, and ideally an arterial line. When weaning, taper slowly. Abrupt withdrawal can cause rebound bradycardia. Before starting, correct electrolytes, especially potassium and magnesium. Expect the mean arterial pressure to drop. Preload and Pressor support may be needed. Think of isoproterenol as pure beta fire, fast, bright, and short-lived. It's not a maintenance drug, it's a bridge. To recap, isoproterenol is a precision tool for rhythms where rate and AV conduction are the problem, and vagal tone isn't the lever. It's first line as a chemical pacer in transplant hearts, and a high-value bridge in atropine refractory bradycardia, or nodal level AV block while pacing is arranged. In pause-dependent Torsades, keeping the heart fast prevents the next R on T. Pair it with magnesium and consider overdrive pacing. Always titrate to perfusion, support map if needed, and hand off to definitive therapy early. Screenshot this slide and the next slide for a quick go-to clinical reference. Isoproterenol's primary strength is chronotropy, not inotropy. It increases heart rate and cardiac output, but often at the cost of lower pressure. Use it as a temporary bridge until pacing or recovery takes over. Always balance flow with perfusion. That's isoproterenol, the beta blazer that lights up the heart's rhythm when everything else fails. Use it with precision, respect, and vigilance. This is Pulse&Pressors, reflecting on the marvels of the human body.